Today we have the privilege of interviewing Emily Johnson, who is a registered nurse and works in the neonatal intensive care unit at a local hospital. She's going to talk to us a little bit about the patients that they care for in the intensive care unit and how they feed these little patients. So welcome, Emily.
Thank you.
Well, tell us a little bit about your education and work experience.
Well, I am a graduate of UAB. I got my BSN from there and briefly worked in pediatrics at Children's of Alabama, but pretty quickly made the move to neonatal ICU or NICU, which is kind of what I love. I worked at UAB for a while in their regional neonatal intensive care unit. It's pretty much the sickest babies in the state, and then moved for my husband's job and now work in a level 2 neonatal ICU, which is slightly less sick babies, not as many ventilated babies, and not quite as premature.
Explain to us these levels of care that's provided in a NICU.
Okay, we have 3 different levels of neonatal ICUs. Level 1 would be just kind of your basic rural hospital stabilizing NICU. They could do some IV antibiotics or glucose control in a newborn, but they're not going to do intubation and ventilation or take care of the really small preemies. They would transfer those elsewhere. And then you have a level 2. And that's going to be a smaller NICU, but they can still do ventilation and central lines and that sort of thing. But if a baby is really critical and needs something called an oscillator, which is a really high-tech vent that gives really quick breaths for those really sick babies, or ECMO or something like that, they're going to send that baby to a level 3, which is something like the regional NICU at UAB, and they are pretty much qualified to take care of all ranges of babies to do. They have the equipment and the know-how to take care of the sickest of the sick.
Okay, it's very interesting. So what types of patients do you treat where you work?
We have a large range. We take care of babies from 21 weeks gestation all the way up to really a year old, depending on their diagnosis. The 21 weekers, of course, you're taking care of them for a long period of time, but then we also get babies that are term that just need some help with glucose control because mom had gestational diabetes, and so they can't regulate that glucose just yet. Or we have term babies who are having respiratory distress, which is usually caused by some sort of infection, or even just something as simple as hyperbilirubinemia, which is jaundice, or those yellow babies, and we just keep them under the belly lights for a few days. So it's a really broad range of patients.
Okay. Well, what are the feeding and nutrition goals in the NICU? Because that's what the purpose of our lecture is today, to talk about how you feed this very specialized population.
Right. Well, upon admission or at birth, most babies are made NPO or nothing by mouth for 24 hours. And that's just kind of to regulate their glucose really closely with IV meds. We usually start them on D10 with a peripheral for those first 24 hours. And then at 24 hours, depending on their age and how stable they are, we'll either start them on TPN, or if they're a big baby, as we call them, or a term baby, we'll start them on feeds. And then those tiny babies that are starting on TPN, we usually also start them on trophic feeds at 24 hours of life.
Now, I know the goal is to get a baby off of TPN as quickly as possible,
right,
to avoid central line infection. Mm-hmm. So talk to me about weaning from TPN to the enteral or trophic feed.
Okay. So usually they're started on their trophic feeds while they're still on the TPN. That first feed can usually just be a swab of breast milk in the mouth if we have it, or if not, we'll give like a cc of formula to start, and then raise it usually a cc or so every day, or milliliter every day. And then from there, we have what we call feeding protocols at some hospitals, and that just guides us on increasing the feeds. And then usually by about a week, they're getting enough nutrition through those enteral feeds that we can take them off the TPN. And we may still keep them on like a D10 or something to keep those fluids up, but we will at least wean them off of that TPN because they won't need that type of nutrition anymore.
Go a little further on what is a trophic feed.
Tri-bit feeds are really small feeds that are used to prime the gut. These babies are born so early, they're not supposed to be eating yet. They should still be in the womb, really. So we have to really take our time priming that gut and getting it ready for digestion. And by giving them small feeds, small bolus feeds at a time, that just helps that gut to kind of wake up and learn how to start digesting these nutrients slowly.
Now, one of the reasons that you want to give small trophic feeds is to prevent necrotizing enterocolitis. Talk to us about that very devastating problem that can happen in this population.
Necrotizing enterocolitis, or NEC is what I'll call it from here on out probably, is a terrible disease, kind of unknown etiology. We really don't know exactly what causes it, but it's most common amongst the really premature babies and very low birth weight babies, although it can occur in a term baby occasionally. It usually happens in 2 to 3 weeks of life. It can happen up to a few months of life, especially in the preemies. And it is a infection of the gut that causes necrotic bowel tissue. And so it can range anywhere from just needing a baby to be on antibiotics for a few days to having to remove large portions of the bowel because it's dead or perforated, to death, unfortunately. It can be very, very sneaky. I've seen babies be eating by mouth and on room air, and then a few hours later even, their gut's blown and they perforated, and it's just terrible, a terrible disease.
Wow. What are some of the warning signs of NIC?
So every every feeding, we do bolus feedings, we do an assessment, and that's every 3 hours. There are certain things we really want to look for in preventing NEC and catching it early. We always check for residual in their feeds. Most of these babies are fed through nasogastric tube or orogastric tube, and so we pull back using a syringe to see if there's any undigested formula or breast milk in their gut or in their stomach, and that cues us in on whether or not it's digesting properly. If we have more than a third of the feed left or that comes back, we usually think, okay, something's not quite working right in there. And we also look at the color and consistency of it. Of course, we want it to look like partially digested breast milk or formula. But if it's lime green or looks like Dr. Pepper, that's a good sign that something's not right. And so we'll get an x-ray and start investigating further of whether or not they might be what we call necking out. And then we also we measure their bellies every feed. Any increase in diameter could be a sign that maybe something's going on in there. It could just mean they need a good bowel movement, or it could mean that they might have that infection. We also, of course, feel the belly. We want it to be nice and soft. And we look at it sometimes if it gets gray or kind of purplish looking, and it looks big, or gets something called bowel loops, which is where you can basically see the intestines through that abdominal wall. Those are all signs that we might need to start some treatment for possible NEC.
Okay, and treatment would be?
It depends on how advanced it is. There's staging of NEC. In the early stages, you're going to make them NPO, start them back on TPN or continue TPN, and put them on IV antibiotics. And you're also going to want to go ahead and have surgery following them, because in the later stages, they may need surgical intervention. If they've already perforated, they'll definitely need surgical intervention.
In our lecture, we talked about what's recommended for feeding babies: mother's milk, donor milk,
right,
or premature formula. How do you acquire donor milk for these NEC babies if mom's not able to provide that?
We have something called donor milk banks now, and they collect the milk from moms who are willing to donate. Sometimes it's moms who had just leftovers from when they were pumping for their babies, or sometimes it's even moms who have lost babies that want to give back. And they actually pasteurize the milk and make sure that it's free of any type of pathogens or diseases. And they individually draw it up into syringes and send it to us to use to our babies. And of course, the parents are always consented. Some parents don't want someone else's breast milk for their baby, but we always try to really educate them on the benefits of even using someone else's breast milk over formula, and try to get them to consent to it.
Excellent. And we have some pictures to show the class of a formula room where this donor milk is handled and processed in some coming segment. We're returning to our more general topic of neonatal nutrition. What are some of the major differences in feeding a premature baby versus full term?
Preemies can be little stinkers when it comes to feeding. They, of course, have a really traumatic entry into the world and have been intubated and haven't automatically had that sucking reflex stimulated immediately. And so they a lot of time will have oral aversions. They don't associate sucking with that positive reinforcement of having their belly full like term babies do immediately. So they often don't want to feed. You'll stick a bottle in their mouth and they just revolt. They'll gag, they'll spit, they'll move their heads around. They hate it. So it's really important to early on start stimulating their mouths positively, not just sticking tubes down their throat and all of those things. So we normally will do some things to prevent it, such as giving them a passy while we do their tube feeds. Sometimes we'll even just do like little finger swipes just to get them used to having something in their mouth. Gently, and but sometimes that doesn't work. So sometimes they will need either a speech pathologist or a physical therapist to come work with them, or occupational therapist to come work with them, depending on the hospital. And they'll usually develop certain exercises that the nurse will do and that they will do to help really develop that ability to suck and swallow and breathe.
Okay.
They also have had respiratory issues in the past, and sometimes that causes issues with breathing while they're sucking and swallowing. They'll do something called desat, or have desaturations, which is where their oxygen saturations drop while they're breathing, while they're trying to eat. And so that's something else that an OT can work with them on, as really pacing them. And so you have to kind of let them take a few sucks and then take the bottle out and let them breathe for a little while, and then just really being patient with them while they learn how to coordinate this.
And we also have some photos to share with the students of the feeding clinic there at UAB and at the pediatric hospital. We have seen these children when they get older and graduate from the NICU actually come to the feeding clinics where I work.
Right.
And it's really fascinating to get these children to move beyond that oral aversion and develop those motor skills that will enable them to move on to other foods. Talk to us a little bit about specialty formulas that are used in the NICU.
So of course, the big babies, they normally have formulas that are about 18 calories an ounce, and with our preemies, they need more than that. They also sometimes need higher protein. So we have various formulas. A lot of them are called Sim Special Care or something like that, that provide either higher calories or higher protein, or both, depending on the baby and what the doctor wants to order for them. Since these babies are so tiny and they really need to gain a lot of weight and grow, we want to give them higher calories and higher protein in a smaller concentration so that we can get them ready to grow up and go home.
So we have 22 calorie per ounce formula, 24,
and 24.
As high as 30, I believe.
We do.
Okay. 18 is interesting now. I thought most standard formulas were 20 calories per ounce, but they have an 18?
I've seen 18 to 20, yeah.
Okay.
I guess, yeah, you're right. Our formula that we feed our babies is usually 20. And we do have specialty care formulas that are 20 calories as well, but they have higher protein and some more vitamins in them.
Right. Okay. Well, thank you very much. This has been very interesting. We appreciate you sharing with the class.
Yeah, thank you for having me.